Good morning, everyone. And today we are starting our first session with none other than the stalwart of diabetes and endocrinology in our country and a global stalwart in diabetes and endocrinology who's been the author of so many books. With me today is Professor Nihal Thomas.
You're making me laugh. Thank you.
Oh, no, sir, I'm not. Sir is professor and head of Unit 1 with the endocrinology with Christian Medical College, CMC, which is also called as CMC Vellore, and associate director with CMC, Christian Medical College, CMC Vellore. So, welcome to the show and ESITV.
Thank you.
It's a pleasure to have you in this show today.
Thank you.
Not just because of that you are an expert, but you are a professor by excellence, a teacher by excellence, and author of it, of so many. To be in the same frame is a privilege and an honor. Thank you so much. So there are a few questions that we would like to understand from your experience that it is there. Why is it, what is this young onset and why the incidence of young adult onset of diabetes? What do we mean of it? What does it general people mean and what do doctors understand of it?
So, when we talk about young onset diabetes in India, we are referring to a heterogeneous group of disorders, what I would call apples and oranges. Having said that, the commonest cause for young onset diabetes in India would still be type 1 diabetes. And when we say young onset diabetes, we mean age below less than 30 years. It's important to realize that beyond type 1 diabetes, which presents with its classical symptoms of weight loss, polyuria, polydipsia, and tend to be GAD antibody positive and have low C-peptide levels with normal imaging of the abdomen, we should consider a number of other differential diagnoses. The differential diagnosis for young onset diabetes in India, therefore, include another very important condition which is typical to be occurring in tropical countries, and this is called fibrocalcific pancreatic diabetes. This disorder is characterized by weight loss, steatorrhea, and by the third decade of life is associated with diabetes mellitus. Patients also have recurrent abdominal pain. They typically do have low C-peptide levels. However, they are GAD antibody negative and have an ultrasound abdomen showing an atrophic pancreas along with calcification within the ducts. The other important differential diagnosis for young onset diabetes in the country include that of maturity onset diabetes in the young, which typically is an autosomal dominant inherited condition. It's important to realize that there are a number of these forms. Having said that, there are certain forms like MODY 1, 3, and the ABCC8 mutation, which are typically associated with response to sulfonylurea therapy. And therefore, it is important to recognize these conditions through genetic testing so that we may be able to avoid giving insulin to young people who have these mutations. Beyond these conditions include another set of genetic disorders which include resistance to insulin, the lipodystrophic forms, ketosis-prone diabetes, which occurs in a slightly older age group. They tend to be having a slightly higher BMI, but they are associated with ketoacidosis at the onset and subsequent improvement in beta cell function with good glycemic control, and we could revert from insulin therapy to oral hypoglycemic agents and dietary therapy within a period of 1 year. Beyond this, one should consider undifferentiated forms of diabetes, what was traditionally called the malnutrition modulated form of diabetes, which is no longer there in the WHO classification, but is once again a condition which is found in rural areas, those who are malnourished, and they are associated with a decline in beta cell function, have moderate requirements of insulin, and do not develop ketoacidosis. So these are, in a nutshell, the important causes for young onset diabetes. Certain other causes which are pretty obvious include hormonal excesses. For example, you may have patients who have glucocorticoid excess, therefore Cushing syndrome, which may cause hyperglycemia, and acromegaly with growth hormone excess. These syndromes are, of course, obvious when we look at the patients and we examine them. The clinical diagnosis is generally not much of a problem.
So, sir, how would you advise a young physician or a young endocrinologist to approach such patients? What would they do in terms of diagnosis? How do they look into it? How do they take it in terms of management?
So one has to have an absolutely pragmatic approach to these patients, and there is nothing better than taking an extremely detailed history, looking at the point of time of origin of the disease, the process in terms of how rapidly it's had its onset, the kind of therapy that the patient has had in the past, presence or absence of ketoacidosis. Furthermore, on examination, one looks for features of abnormal distribution of fat which occurs in lipodystrophy, features of syndromes like Turner syndrome or Klinefelter's, which are once again physically obvious, and these conditions also being more prone for young onset diabetes. Looking at the overall nutritive status of the patient, and which is generally emaciation in patients of fibrocalcic pancreatic diabetes and malnutrition modulated diabetes mellitus. Beyond this, one would have an investigational battery, which is fairly empirical. One would initially approach these patients by having good glycemic control and measuring a C-peptide level, fasting and postprandial. If the C-peptide levels are low, it would indicate low beta cell reserve, which happens in type 1 diabetes, fibrocalcic pancreatic diabetes. If the C-peptide levels are in the intermediate level, it indicates suboptimal beta cell function, as in patients who have MODY, and in patients who have high C-peptide levels with an associated elevated HOMA-IR index, one would therefore consider insulin resistance as associated. GAD antibodies are important, particularly in those who are patients who are young and who are lean. If the GAD antibodies are positive, they would tell you whether the patient has autoimmune diabetes, therefore type 1 diabetes. If GAD antibodies are negative, that would take you along a different trajectory in terms of your investigation. Imaging of the abdomen is important because atrophy of the pancreas, dilated ducts, and stones within the ducts of the pancreas are typical of fibrocalcic pancreatic diabetes. Certain forms of MODY may be associated with abnormalities in the abdomen, like renal cysts in MODY type 5.
So you also mentioned about the genetic origin of diabetes in these patients. So what are the most common genetic problems that and abnormalities causing this? What is it?
So therefore, the commonest genetic disorders which are associated with diabetes include the inherited forms, which are roughly divided into those with defects in beta cell secretion and those with insulin resistance. The ones with beta cell secretory defects encompass a category of disorders called MODY, or maturity onset diabetes of the young. There are 14 types. However, in the Indian context, it is essentially MODY 3, 1 and ABCC8, which are all sulfonylurea sensitive. And in addition to that, the NeuroD1 mutations and the PDX1 mutations, which include MODY 6 and 4, which appear to have an increased frequency in our population. Having said this, when one makes a genetic diagnosis, it requires sophisticated testing. And to be cost effective, we now use something called next generation sequencing, which we have available in Vellore. The entire process of sequencing and interpretation is done over there. Having said that, when one is in a remote or rural area, we may have to depend on tools like a good pedigree chart, which is extremely important in genetic testing. One has to take a good family history, draw a pedigree chart, and measuring C-peptide levels would also be useful. And then trying to treat these patients without the help of sophisticated testing in an extremely remote or rural area. The other category of genetic disorders include those where you have extreme insulin resistance. These include certain conditions like Rabin-Mendenhall syndrome, leprechaunism, which are rare and occur in childhood and are generally not compatible with life for a very long time. Having said that, there are conditions called lipodystrophies, wherein there is an abnormal distribution of fat, partial lipodystrophies, wherein there are increased amounts of fat in the upper parts of the body, and a complete lipodystrophy, wherein there is an almost absence of subcutaneous fat all over the body with stunting of growth. There are specific mutations in each of these conditions, and these can easily be identified through either next generation sequencing or Sanger sequencing when we talk about genetic testing. It is important to identify these conditions because they are associated with an early onset of fatty liver, which could progress to cirrhosis at a very early age in life. They have extremely high requirements of insulin for their therapy, sometimes up to 200 to 400 units per day. And in spite of this, when insulin is stopped or the patient defaults from insulin, they do not develop ketoacidosis. Some of these patients may respond to small doses of pioglitazone in addition to the insulin therapy that they require.
So what I gather from your talk and what you're saying right now is that genetic testing is also important for diagnosing which type they are, but also would have an implication in the way that you're going to manage them.
Yes. So as I mentioned, certain types of disorders like MODY or maturity onset diabetes of the young are responsive to sulfonylureas in very small doses. And we can avoid giving insulin therapy to these patients on a long-term basis by identifying them through the mutations. Beyond therapeutic purposes, there's something called predictive screening. So if I pick up the mutation in the index patient, in the patient who has the disease whom I detected the problem first, I would then go on to screen the patient's parents, the patient's children, and the siblings and the cousins. And I would potentially be able to pick up the disorder early before it becomes clinically manifest. This is extremely important in certain genetic conditions wherein the onset might kick off in childhood. And if you do the testing at birth, you can predict that perhaps this problem might occur and be ready for treatment.
Okay, and so the future would be, if I would just put it across, that we've got to check it across someone who's going to develop diabetes, manage it well beforehand. So probably the person who is inclined to have it because of the genetic mutation may not get it or would be managed better. Would that be the future?
Can you repeat your question?
So my question is the way how we are learning more about the genetic mutation and its implication. Is it that in the future generations to come, would we be able to screen the children before and give them lifestyle modifications much before the onset of the disease comes in, and probably have less complications or a better managed diabetic population in the future?
So these are disorders which have less of an influence in terms of the environment on the disorder. Perhaps physical exercise and diet may not play as much of a role. Having said that, of course, if they do put on weight, they could overlap with the type 2 phenotype and develop the disease much earlier. In addition to that, we will reach an era in the next 10 to 20 years where the cost of genetic testing might come down. And this will be the era of precision medicine, wherein a number of subjects or patients may be enabled to have the testing done early. And as you said, we would be able to provide treatment at an early point of time and prevent both the microvascular and macrovascular complications of diabetes in these patients.
Thank you so much, sir, for your real great insight. It's a pleasure always talking to you, and the learning that we gather from you is certainly immense. Thank you so much for your time.
Thank you so much.
Thanks a lot.
Thank you.